combination. Okay. My height is okay.
Kerala 2003. Presently posted and papers in various conferences, national, south and state conferences, and faculty. He has been invited as a speaker for National South Zone, Kerala State and Anaesthesia CME. He has done 7 international publication and national journals. Sir has done one clinical trial on effects of intravenous dexmedetomidine on perioperative hemodynamics and quality of emergence in patients during head and neck surgeries following general anesthesia. He has association with professional bodies of active lifetime member of ISA since 2001 and served ISA in various capacities. Currently reviewer of English Journal of Clinical Anesthesia from 2020. His areas of interest is anesthesia in laser surgery, ICU management, central venous cannulation, difficult airway, and one lab ventilation. Over to you, sir.
Thank you for the very exhaustive introduction. That's what the resume I gave to the organizing team. Okay, you read the whole thing. Okay, thank you. And it's good afternoon to all the audience members. And my job is easy because I don't find any postgraduates actually sitting here. So I thought I have to prepare from top to bottom. This is a laser and anesthesia. So I thought I will prepare from the whole topic, but it's only very few postgraduates, so I can rush through the slides probably. So this is the Regional Cancer Center. Greetings from RCC where I work. Last 23 years I am working here. And we are doing laser surgeries not very often, but probably 3 or 4 a month. So over the more than 10 years we are using on carbon dioxide laser, and that's I can share some of my experience also. So straight away we will go to the laser. Laser is an acronym for light amplification by stimulated emission of radiation. So this is a slide for postgraduates actually. It's for laser physics. Maxwell described light as an electromagnetic radiation, and Max Planck's theory of photoelectric effect was the first step towards laser physics. Then the Albert Einstein came with the quantum mechanics, and combined with the photoelectric effect, they published the theoretical basis of laser in 1917, and in 1957, A.L. Shavlo and C.T. Towns invented laser. So actually for postgraduates, it can be a question for the quiz program. So light and laser, are they same? No. We all know that light we can see, but laser we can't see. So why that difference is there? Because light falls in the visible spectrum and laser in the invisible spectrum. And the qualities of both are also different. Laser is monochromatic, coherent and collimated. That means monochromatic means same wavelength, and coherent means they go in the same direction, not like light. Light passes in all directions, and it is collimated. That means they travel in phase. Oscillations are in phase, whereas in the light it is not in phase. So they are totally different. They come to different spectrum. So as an anesthesiologist, when you go for laser surgery, we have to have a good idea of the principles of laser light, the types of laser we are going to use, the hazards of the laser and airway management to have a safe laser surgery, and prevention of complications, and approach if an airway fire occurs. Why I put it as red letters, because we forget about that. We forget that how to prepare for a airway fire, or what to do in an airway fire if a fire occurs. And most importantly, when we do a lot of laser surgeries on airway, that means the vocal cord and leukoplakia of the tongue, buccal mucosa. So we are doing a lot of oral surgeries where we share this airway with the surgeon. That's I told that for us it's a major concern, because we are sharing the airway with the surgeon. So carbon dioxide laser we commonly use in our center, and because we have a lot of ENT procedures, I told we are doing a lot of ENT procedures with the carbon dioxide laser, and it comes in the infrared spectrum. It's invisible. It produces intense thermal injury. the quality of laser is it carries a very high quantities of a very high intense energy which can burn the tissue, and tissues can get evaporated, and the lesion can just go off, just vanish. But only thing is that you need an aiming beam to focus the laser energy to the point of interest, or point to the point of surgical field, and ensure that this is accurate to the laser before start. It's not pointing to some other point. It's pointing only to the focus of interest. So that is very important. Then only you start the laser surgery. That the surgeon should make sure, and we should also be insisting on that. Then eyes of the patient, because it's all on the over the face, so eyes of the patient is very important, and OT personnel as well. So we have to provide protection to eyes of both. So I told why the laser surgery is not done in all hospitals. Only certain hospitals are doing laser surgeries, because it needs special device, special equipment for that, and it needs special preparation, and you have to follow certain guidelines and algorithm if any fire occurs. So when it is done under strict protocol and strict conditions. So the advantages are the dry and bloodless field. There is no bleeding at all, because the vessels are getting only small vessels, and they are getting coagulated, and less postoperative pain because the nerve roots are getting sealed off. Sterile, because there is no instrument coming to the field, and it is burning. It's intense beam, intense burn, so there is no chance for any bacteria or anything to survive there. And rapid wound healing. There is a clear field. Again, no instruments, clear field. Wavelength specific, because the effects can be wavelength specific. Microsurgery is possible, because the surgeon can use the operating microscope. He has the full area to operate, full visible. And precise, it's a very precise cutting tool, and it's computer programmed. So various types of laser being used, the list of lasers and their applications are shown. It's from the textbook. And when you use laser, your OT should have your OT door should have this symbol or this board, which is recommended by the International Electrotechnical Commission, that laser surgery is going on, so unwanted entry should be avoided. So, or somebody coming out will know that laser surgery is going on. So, coming to the laser specific hazards. So, one is the laser plume. So, what is a laser plume? It is from the burnt or evaporated tissue coming, the noxious fumes coming out. You need a smoke evacuator to suck out or remove those fumes. Another one is the gas embolism, which is seen commonly in Nd:YAG laser when we use for hysteroscopy. Another one is the inappropriate energy transfer. I told that if you are not aiming the beam at the point of surgical interest or or the disease, you can injure other tissues, and probably the drapes, probably the patient's other areas, or the OT personnel, or even sometimes it can pass through the glass door or glass windows also. So be careful on that. So the plume can produce atmospheric contamination. I told that the tissue gets intense thermal energy, there is burning, and there is evaporation of the tissue, produces aerosol or smoke plume, which is has got very noxious gases like polyaromatic hydrocarbons, hydrogen cyanide, formaldehyde, and benzene, etc., which is dangerous or which is harmful to our lung. So usually the particle can range from 0.1 to 0.8 micrometer, and our usual face mask can filter only particles up to 3 micrometers. So this is much below that particular range. But when you use a high efficiency mask, what we use for laser surgery, it can filter up to 0.3 micron. So a major protection we can get by using this high efficiency mask. And this noxious gas is said to be carcinogenic, mutagenic, and they may contain dead viral particles or DNA, but there is no transfer of or development of any disease, any viral disease. The transfer of any viral disease is not reported in humans. So only theoretical possibility is there, and that too dead particles only. So eye injury is very seriously should be considered. That means you have to protect the eyes of the patient as well as the OT personnel. Because corneal injury can be there, retinal injury. it can cause permanent visual defects. So you have to use safety goggles or glasses. For carbon dioxide laser or ordinary glass, ordinary white glass is more than enough. But for different, when you use argon or NDAG or any other different types of lasers, there may be a different glasses has to be worn, and there are different filters you have to use. And the other, this thing shows, the second photo shows that metallic shield for eye protection also. So I told you that the operating surgeon, you can see in the photograph that the operating surgeon is operating with a microscope with a carbon dioxide laser. So we can see that the face of the patient is covered with wet soaked mops, and the drapes, you can see that the blue drapes, that should be ideally that fire resistant. It should be soaked or wet or fire resistant material should be there. And you can see the bucket of water there. Can you see that bucket of water on the trolley? So that should be ready, and there should be a syringe ready, 50 ml syringe with saline or water should also be ready. In case of fire, you have to use both of these. And there should be carbon dioxide fire extinguisher available in the OT. So this picture shows that the ET tube, commonly used for polyvinyl chloride tube, you can see that the tube get burnt and there is a resultant blowtorch fire. You can see the tip of the fire coming out from the tip of the tube, which can damage our trachea or our bronchi and our lung beyond the trachea. So that can cause a very serious injury. So if the fire is not identified, you can result in a blowtorch fire. So there are a lot of strategies to prevent airway fire, and one is the metallic foil taping over the tube, which we usually used when we started our laser surgery in RCC. We were just woving around our aluminum foils over the endotracheal tube, PVC tubes, and we using an adhesive, and we were using it for oral surgeries. But we found very difficult. But later on, we got laser resistant tubes or laser tubes, which were more safer. So there another is a Mirocell laser got coating available with that coating tubes are available, and then came laser resistant endotracheal tubes and laser safe, the so-called laser safe. But it's a misnomer. It is not absolutely laser safe because there are certain parts of the tube where you can get fire. So precautions, prevention of fire is of utmost importance. This is a technique of how to wind the aluminum or the metal foil over the endotracheal tube. So there are like the tube, covering the tube with the foil, metal foil, there are certain strategies to protect the cuff also, because the cuff is in close proximity to the laser beam, so you have to protect the cuff as well. So what are the strategies? You can use air or saline, but better you use saline, because if at all cuff ruptures, the saline will provide a heat sink. So there is less chance for a fire to broke. So it's safe. Methylene blue is used by some of the tube manufacturers, so it can easily recognize that cuff has ruptured. So methylene blue crystals are provided in that cuff, or you can use a methylene blue solution as well. And another thing is that you can place the cuff, tube cuff, little more distal or as much distal as possible, and you can use a twin distal cuff. One of the tube I will show you, two distal cuff, where first one ruptures, the second one will be there to protect the airway. So this is the one tube tip. We can see the cuff is blue colored, filled with blue colored methylene blue, and you can apply cotton blood jets at the operating site, also near the operating site or the ocal cord, and you can do surgeon can operate. So we will see some of the laser resistant tubes we commonly use. This is the, sorry I can't zoom it, it's from the textbook, so it's there and available in the textbook. So these are various type tubes, laser flex, laser shield, two laser tubers and Sheridan laser track. All these are available in the market, and this is a totally laser resistant. There is totally metallic tube. Pediatric size and adult size are available. It's a stainless steel tube, You can see even the connector is steel. And this is the photograph of a zoomed laser shield 2 endotracheal tube. Again, the how it is prepared is I have given the thing. It's again a metal tape over a this thing over a silicon based tube, and the metal is I think it is aluminum or I think copper. Yeah, so that metal provides protection against laser, and there is a Teflon tape which which minimize mucosal injury. And laser tube is another tube where again aluminum metal foiling is there, and there is a cuff within a cuff. That means two cuffs are arranged in series, one cuff over the cuff. That's also available. And this is a Mallinckrodt tube, laser flex tube, and you can see that the tip and the cuff and the connected portion are not laser resistant. So laser Sheridan laser track tube is also available. So this photo shows some of the tube damaged by the laser surgery. So principles of airway management, I have to rush through only 1 or 2 minutes available. So principles of airway management is very important. We have to have a good preoperative assessment. We have to assess the airway of the patient. Is it difficult? Should the patient go for a spontaneous ventilation or a controlled ventilation? So our history as well as laboratory findings like pharyngoscopy, CT, MRI will give you an idea regarding the airway status. So based on that, we have to plan for an anesthetized or awake technique of intubation. So you have to have all the arrangements ready. I told that it's different from other surgery. You have to keep the difficult airway card ready, rigid bronchoscope, jet ventilator, tracheostomy standby, and induction ventilation method planned with the surgeon sitting together, and backup tracheostomy. And decide whether you are going for a spontaneous ventilation or a controlled ventilation, and particularly in adult and pediatric cases. Induction ventilation as usual, but can be challenging when there is a problem with the airway. Then gas mixture, always don't use more than 30% of oxygen. So limit your FiO2 to less than 30% or keep it around 30%, and even nitrous oxide is not allowed because a mixture of oxygen nitrous oxide is said to be 100% chance for ignition. Sevoflurane is supposed to be safe. Recent all the newer inhalational agents are supposed to be safe, Sevo and DES, but the only thing is that in case of fire, in case of ignition, this sevoflurane can get pyrolyzed to toxic compounds. So there is only problem with that. So technique of intubation, airway management and anesthesia are like non-intubation or intubation techniques, and the non-intubation techniques you can go for apneic oxygenation, spontaneous ventilation or jet ventilation, and intubation techniques. I can just summarize that. Apneic oxygenation, there are some advantages like you can apnea is there, and then the surgeon can operate, and again it will alternate with the apnea and surgical resection of the surgeon. Then provide excellent visibility, and trauma to the airway is also avoided. Disadvantages are surgical time limit is limited, inadequate ventilation is a possibility, and there is a possibility of aspiration risk also. So spontaneous ventilation advantages are being you can have the cord function evaluated, visualization is good, and unstable patients where there's airway obstruction is there or a compromised airway is should be advantages. And disadvantages are oxygen ventilation ratio, ventilation maybe some difficulty to assess, and surgical field not still, and risk of aspiration is there, depth not consistent. So jet ventilation again has got some advantages and disadvantages, and surgical field there is improved visibility, but the thing is that they can cause barotrauma and gastric insufflation. Again there is chance for hyperventilation, so muscle relaxation may be required. So these are the advantages and disadvantages. Just have a few slides on airway fire management. So to fire to occur, there should be an ignition source, there should be a fuel, and there should be an oxidizer. So when these three comes together, it will cause fire. So management of fire is discontinue surgery, stop your ventilation, disconnect oxygen from the source, disconnect the circuit from the tube and machine, and remove the burnt endotracheal tube. You just douse the area, douse the field of operating area with the water. I told you to keep the syringe or water in the bucket. So pour that and restart ventilation. Start with mask ventilation, and if you want to assess the do the laryngoscopy and re-intubate if needed, and ventilate in room air. and bronchoscopy is available. You can see you can assess the extent of damage and remove any foreign body. Tracheostomy may be needed because this burnt airway can later become edematous and there can be a difficult airway. So you have to go for a standby tracheostomy. Steroid therapy may be useful. Antibiotic therapy also required, and the patient has to be transferred to critical care unit or ICU. So there is an operating fire algorithm is available in the text. So we can, it's a very elaborate one. So theatre safety is taken to be considered. Only the trained person should use the laser. So the technician should be trained, assign role to each person in the OT. The only keep it standby mode or off mode when not in use. Regular servicing of equipment is important, and so there should be theatre lock. Should be theatre. There is a system that theatre can be locked for, so no one can enter into the OT while laser surgery is going on. That's all. Thank you. So wish you all a happy Onam, because it's a major festival in Kerala. It's coming in the end of August, last week of August. So wherever there is a Malayali, there is Onam, even in Ladakh or in Trivandrum or in any other part of the world.